also so significant by this procedures compared to the medical management. And what are the complications? So there can be general complications like sepsis, bleeding, cardiopulmonary, and death. Also, the rate of death should be very low in the appropriate setup. These are the potential complications associated with this specific type of this surgery, like strictures, band erosion, gallstone formation is very important, side effects in all these procedures, and gastrogastric fistula and marginal ulcer, nutrition deficiencies, all these things can occur. We should be aware of this and provide the adequate nutritional supplement after the surgery. And what are the results? So the mean ratio of patients to the resolution of the type 2 diabetes remission can be achieved 48% with the gastric banding, and vertical band gastroplasty 68%. The maximum of 98% remission can be achieved with this duodenal switch surgery. And we can achieve the non-glycemic effects also. So there will be improvement in hyperlipidemia and hypertension. So these are the take-home messages. So when the behavioral and the pharmacology interventions fail to manage, we can consider bariatric surgery, and the careful patient selection is very much important for the better outcome and to prevent the complications. Those bypass techniques improves glucose homeostasis through mechanisms beyond reduced caloric intake and weight loss. So thank you for the patient listening.
Well, thank you, Dr. Joseph, for a good talk. Who is going to talk on polypharmacy, and I think the polypharmacy has become mandatory nowadays, and we cannot avoid it. Of course, with the advent of AI, in few years' time or in a few months' time, the patients will be sitting in front of us talking about drug interactions and so on. We should be prepared for that. Let's see what Arthikaran says about it. Thank you.
Adults worldwide, hence necessitating more innovative therapeutic approaches. The limitations of the current treatment approaches are the monotherapy limitations, that is single target medications which offer insufficient glycemic control, and the treatment burden of multiple tablets, poor adherence, increased costs, higher risk of drug interactions and adverse effects, and also inadequate weight management because of our traditional diabetic medications, hence failing to address the obesity component. So these limitations highlight the urgent need to bring about more comprehensive treatment strategies to address the multiple aspects of metabolic dysfunction. So as the years have gone by, in the last 2 decades, obesity management, we start with lifestyle changes, then behavioral therapy, which has found to cause only 3 to 5% of weight loss. So we have started them on pharmacotherapies, and the older pharmacotherapies we had did cause only about 5 to 10% weight loss. In the last few years, we have seen a great leap, that is in the development of new molecules like the GLP-1 analogs, which are showing a very big ray of hope for our type 2 diabetic obese patients, and the newer molecules which actually revolve around this GLP-1 analog is going to actually replace even bariatric surgery soon. So recent research has revealed complex interactions between the brain and the body in regulating hunger and energy use. The discovery of leptin initially did raise hopes because it promotes fullness and increased energy burn. However, its effect in obesity was found to be limited. So now going on to the paradigm shift of this unimolecular polypharmacy, it is a single molecule engineered to activate multiple receptor targets, and each component of the molecule do not interact with each other. They act separately on their receptors, and they maintain their individual identity and integrity. They overcome the limitations of traditional pharmacy. Polypharmacy provides synergistic effects, simplifies treatment regimens, improved adherence, and reduces the pill burden too. So going on to this GLP-1 analogs, they are mainly produced by the intestine in response to food. They cause glucose-dependent insulin release, they slow the gastric emptying, reduces the postprandial glucose exertion, acts on the hypothalamus, and induces satiety and reduces the food intake too. These are the drugs which are available with us today, and also with tirzepatide. This schematic representation shows how a peptide-peptide multi-agonist approach did offer beneficial metabolic profile by targeting the multiple receptors. Let me talk to you about them in a little detail. Going on the milestones of GLP-1, they came into play from 1987, and starting with the exenatide, the liraglutide, then came the semaglutide, and the tirzepatide today. GIP is also produced by the small intestine, has potent incretin effects, promotes beta cell proliferation and survival, modulates adipocyte metabolism and fat deposition. So these two together, GLP-1 with GIP, the dual agonists, despite their double incretin action, neither caused chronic hyperinsulinemia nor hypoglycemia has been observed in various trials. So what does this complementary action actually do? It has a synergistic effect of greater insulin secretion, more adipogenic effects, and also has a multi-organ impact. So this dual agonists have shown superior efficacy in the treatment than when they use the other two molecules separately. So incretin effect is nothing but enhanced insulin secretion after glucose load, and 70% of the postprandial insulin secretion is mainly because of GLP and GIP, and this incretin effect is actually impaired in type 2 diabetics, and this dual agonist has found to actually restore this compromise. And beyond the glycemic control, it acts on the central nervous system, crosses the blood-brain barrier, it acts on the hypothalamus, causes appetite regulation, acts on the brainstem, causes satiety, acts on the mesolimbic system, and modifies the food preference. And the drug we have today in this dual agonist is tirzepatide, which is found to affect type 2 diabetes, obesity, and other metabolic diseases too, which has been proved by the SURPASS program, SURPASS CVOT, SURMOUNT program, and for the other comorbidities, we have ongoing trials. The next dual agonist will be GLP-1 with glucagon. So along with the functions of GLP-1, we talked with glucagon, which is found to increase glucose production, satiety, and also the energy expenditure. And both these dual agonism has found to safely improve the glucose tolerance, hyperinsulinemia, hepatic steatosis, and body weight in various preclinical data. The drugs we have today in the pipeline, the phase 2 trials are cotatudide, pemvidutide, and the survodutide. So the comparative efficacy of the single target therapies to the dual agonists, the dual agonists have shown higher HbA1c reduction of 2.3% and a weight loss of about 15 kg. So hence excellent glycemic control and weight reduction. Next combination dual agonist will be a GLP-1 with steroid that's along with estrogen. Estrogen is found to have leptin-like effect and also found to protect the pancreatic cells from the damage associated with the metabolic disease. But the adverse effects of estrogen like uterine hypertrophy and accelerated growth of estrogen-sensitive xenograft tumors have limited its use. Going into the combination of a GLP-1 with amylin, which is also secreted by the beta cells, this hybrid peptide has shown to improve insulin sensitivity, increase the satiety, reduce appetite, and the energy intake. And the molecule we have is cagrilintide and amycretin. These have shown in the redefined 1 and 2 trials excellent weight loss of 20.4%. Even amycretin has shown a weight loss of 24.3%. The next dual agonist on the pipeline is GLP-1 with CCK, which is an anorexic hormone secreted by the intestinal cells, and this hybrid peptide has also shown superior weight reduction. But we need more clinical data to see on its effects, to see the effects of the gallbladder with this combination. The next on the pipeline is GLP-1 with fibroblast growth factor 21. For this is actually secreted by the liver, regulates fatty acid oxidation and glucose oxidation, has anti-inflammatory role too. And this dual agonist in the phase 2 trial has shown very promising results in reducing the hepatic fat, improving the liver injury markers, and the metabolic parameters in NASH as well as type 2 diabetic patients. Next we have the monoclonal antibody peptide conjugate, maritide, which in the phase 1 and phase 2 trials have shown acceptable safety, tolerability profile, and dose-dependent weight loss. Phase 2 trials are still going on. Going on to the bimagrumab, this has another excellent monoclonal antibody which has been combined with GLP-1, which has shown weight loss with muscle preservation. So in the BELIEVE-2 trial, it has shown to cause excellent weight loss of 22% and along with the reduction of abdominal fat and inflammation-related biomarkers. So here I give you a list of the monoclonal antibodies which are still on the pipeline, yet to come into field. And next we go on to, after the dual agonist, we go on to the triagonist. That is the combined GLP-1, GIP, and the glucagon. And And this, the drug we have, this is retatrutide. In the phase 2 trials, it has shown a weight reduction of 24% and also reduction in the BP, lipids, as well as good glycemic control. Here I have just summarized the multi-receptor agonist, which I've spoken in detail, which shows the effective glycemic control, effective weight loss, and also its other metabolic effects too. Going on to the next combination of tetra-agonists. Here they have combined GLP-1, amylin, GIP-1, and calcitonin. This category has shown the highest quality of weight loss with reduction of fat mass, preservation of muscle mass, and also improvement of the metabolic health of a patient. So you can see this diagram, you can see a single molecule is targeting multiple organs in our body. So next combination we'll be seeing is GLP-1 with basal insulins. Some of them are in the pipeline. Some have come like Igarlexi, Ideglera. Most of you must be using. And just to say, this combination of basal insulin has been addressing 7 out of the 8 pathophysiological abnormalities of type 2 DM has been addressed by this combination of GLP-1 with basal insulins. Other than only glycemic control, it is going to cause weight loss, also lesser hypoglycemias, and improved GI tolerability too, which has been proved by the Solid D trial, Lixican L, Solimix trial have all proved the above. So here I give a list of the key unimolecular combination drugs in the pipeline, in which we have only tirzepatide today with us. Others are still in the phase 2 and phase 3 trials yet to come to us. Does this unimolecular polypharmacy play a role only for obese type 2 diabetic patients? No. It has found a promising role in neurodegenerative disorders, infectious diseases, respiratory diseases, cardiovascular diseases, oncology, and also in metabolic disorders. So the future of our new metabolic therapies is metabolic disease treatment is shifting from symptom management to comprehensive metabolic control. It does offer a broader disease coverage, patient-centric and precision approaches, bariatric surgery-like efficacy with medications, and expanded therapeutic impact. Numerous promising therapies are in the clinical pipeline have been posed for regulatory review. Our field is entering into a new era of effective, convenient, personalized metabolic care, less burden, improved adherence, and ongoing innovation. Thank you very much for your patient hearing. And I will not be doing justice to my talk if I do not pay my gratitude to my guru, my teacher, my mentor, without whom this full talk would not have come out. The best teachers are those who inspire us to be our best selves. Thank you, sir, for being a constant source of my inspiration. Thank you to all.
Thank you for finishing in time, and we have open forum now. Any questions?
Thank you, madam. Thank you for your extensive presentation. Just one practical question regarding the presently available anti-obesity drugs. After achieving weight loss, whether the patients are able to sustain the weight loss, or what will happen if we reduce the dose or stop the drug? What is going to happen?
Sir, what is going to happen is different. Patient, actually, it depends on the patient. He learns to eat less and he'll actually adopt to that lifestyle modification. If he adopts, actually, when we stop the drug, we see about a 10% of weight gain is there. But more than that, it's a habit, behavioral therapy, he has to follow it, sir.
Okay.
Thank you very much for the organizer and as well as for all the delegates. It's an excellent program has been organized by Dr. Bala Murugan and Dr. Rajendran, and these three topics are really wonderful, especially all the topics, and I think they need more time for the presentation or expressing their view. And I just have a doubt with my friend Vengo regarding the intergenerational. It is a wide spectrumic topic, very upcoming topic. Regarding the, he explained about the memory which is being transmitted from one generation to the offspring, even if the person is not exposed to that environment. That is a point of the core theme of the topic. And whether it can be, it is more of an epigenetic pathway. And any suggestion or maybe any data from the national health, I think it has been done extensively in UK. Any suggestion about the arrest the progress, or maybe any precautions or any medical therapeutical approach in breaking the barrier?
Exactly, sir. That is where the research is now targeted and focused. One simple thing is demethylation of the methylated DNA. Sooner or later we are going to be speaking on those molecules. But because they are not even in the phase 2 trials, we cannot speak on those. But definitely this is the future.
Yeah, thank you very much. It's a very extensive topic. And next one is the bariatric surgery regarding our therapy, especially in the weight reduction, has been extensively from the beginning till the end has been told very clearly about the role of bariatric surgery and the outcome, not only for the reduction of body mass as well as the metabolic outcome. And any new points which is being upgraded in the recent time regarding the bariatric surgery, any suggestion from anyone from the surgical side or gastroenterology beyond general medicine?
Thank you for the
So-
opportunity, sir.
Thank you for the chairpersons for the